It's part 2. It's part 2 of our previous discussion. I would like to welcome everyone. Please feel free to switch on your videos so that we can see each other. And don't forget to put your phones on silent and unmute when you're not speaking. Remember, let's not speak over each other. If one person is talking, we give them chance. May we keep our questions brief and precise. Where you're not clear, please feel free to ask. And then let's use language that is respectful to each other. You're welcome once again. So our outline for this session is we're discussing kindly and okay. Yes, as we are saying today, we'll look at we'll discuss the epidemiology and diagnostic measures for the ENT patients with long COVID. We'll also discuss the effects of prolonged intubation in ENT for long COVID patients who are found in ICU. We're also going to look at how we manage these things. Welcome everyone. I'll hand over to my presenter, Dr. Mwale, please.
Okay, thank you, Dr. Chelo. Dr. Mwale has been mentioned. An ENT surgeon. So I'm going to take you in the second part of the ENT long COVID complications, which is the one first we did 2 weeks ago was about, as we know that COVID is one of the upper respiratory tract viruses which attacks the nose and the taste, so loss of sense of taste, and which is called, of course, dysgeusia or aguesia, and sense of smell, which is anosmia and hyposmia. So we looked at that's one of the most common symptoms in patients, but some patients prolong with those symptoms. So today we're supposed to do the second part, which involves patients who have been to ICU. And this is a challenging topic because I believe like sometimes we do not have enough information on the criteria for patients who go to ICU, discuss between anesthesia, ENT, and generally the people who are taking care of the patients, the physicians, on what to do for these patients in ICU. We must know the indications for patients who are in ICU need tracheostomies, those who have been, because as we know that in our space, especially in low and middle income countries as ours, we have restricted surgery or surgical space and ICU, intensive care units. So we must be very highly efficient in using these spaces so as to better serve a bigger or save more lives as per se. So our protocols for those spaces are still being developed. So this is one of the spaces where we had patients who have got ICU, and what has happened to those patients? Some, of course, we know unfortunately passed, some have come out, but some of them come out with complications. So those complications are what we're going to discuss and what role ENT plays in those patients. So let's start the presentation. So, okay. As been mentioned, we already talked about going through the what we're calling long COVID. What is the definition of long COVID? As can be seen, is defined as the development or continuation, either new symptoms or continuation of symptoms 3 months after the initial diagnosis. Or these symptoms usually can come like I said, it's either they prolong, but they should last at least for 8 weeks or 2 months. Then this is a person that you can diagnose with long COVID. So, as already mentioned, we said last 2 weeks ago, we did the hyposmia and aguesia, dysgeusia, and we said what to do with those patients and what treatment, how often they'll present. So today we're going to do the tracheostomy and prolonged intubations complications. So the first thing is just to go a brief definition of the tracheostomy. Definition, of course, it's opening the trachea surgically into the interior of the new neck, so that using surgical means, which can be, the types can be open, where you cut with a knife, which is the most common one, and the one I know so far that we use in Zambia currently. More developed ICUs and surgical areas, they also use closed, which is the percutaneous one. This comes with a set, which you use an introducer, and you put the tracheostomy into the trachea percutaneously without per se cutting. It's useful in ICUs, where you don't have to take the patient to theater, and it's less bloody. It's simpler to put, but it also has got a very specific criteria. You don't use it in children. So we use open, where we have the surgical field and we cut anterior in the neck and we put the tracheostomy tubes. This is a patient who's obviously in ICU, as you can see from the picture. Patient has been put with a tracheostomy tube, is on probably on a ventilator with a connector there, and it is strapped. It is not sutured, so probably this patient has been in ICU, or the tracheostomy has been on the patient for quite a while, which is usually meaning more than 7 days. So these are the patients that you will see in ICU. You will see them on the ward. They come with these tracheostomy tubes. So what happens to these patients once they're discharged or they go home? This is one of the things. Those who got tracheostomies, not only from COVID, but from other indications, you must find out why before you can even intervene. Of course, the other patients we're talking about are the patients who are in ICU and have been intubated. They are with an endotracheal tube. It's got an endotracheal tube. You can even see this patient is sitting up. It's got a nasogastric feeding tube. So these are patients, especially in COVID, you found the patients stayed for a long time, and such that some of them were, you even stopped sedating them heavily, because they are now just suffering with respiratory distress, which was acute, and they are intubated, and the reason that they're being ventilated because they cannot breathe or respire or breathe properly. Therefore, they need an assistance of the vent. Some of them, because of the comorbidities, they cannot maintain their airway, and you have this patient stay there 3 weeks, 4 weeks, and you need the bed space. So one of the answers to removing this patient off the ventilator or try and extubating them, or after you failed extubate, is put a tracheostomy. So why tracheostomy in intensive care units? Why do you have tracheostomy in the patients who are ventilated? So these are the reasons. The patients, of course, one, you've got ventilators like at Levy, we've got Usually we have eight bed spaces with 8 ventilators. So if you have a large number of patients and you have all these patients, the 8, if an average of them are spending 3 weeks there, patient has improved clinically, generally. The infection has settled, but the patient is struggling to breathe. So you want to get them off the ventilator. And one of the reasons is that you put a tracheostomy, they'll be able to get off the ventilator because you reduce the dead space. Effort to breathe is reduced by putting the tracheostomy. Therefore, you can lower the settings on the ventilator and eventually reduce the amount of oxygen, and you can remove them and hook them off the ventilator with the tracheostomy. Therefore, you have a ventilator free, means another patient can use it. Then 2, improvement of breathing and pulmonary toilet. I already said about the breathing, reducing the anatomical and the physiological dead space. And you have the pulmonary toilet. Pulmonary toilet just means that you are forever suctioning. If you have a patient who's on a ventilator or intubated, those are foreign bodies, and especially if you put in juices, reacts to those foreign bodies. 2, the infection itself will also cause a lot of edema of the respiratory airway. So you tend to have a lot of mucus secretions. So you tend to be having to be suctioned. Those secretions stay, bacteria will start growing. Then your patient will end up with the infection in the airway. So if this patient has got excessive secretions, it's not good. So putting the tracheostomy helps the patient to reduce the irritation because the length of where you put the tube reduces. Then 3, like we said, I already said there that the patients who are on endotracheal tube and who have the endotracheal tube who end up with the pneumonia, just like I mentioned, because of the secretions. So the patients who are on the ventilator for a long time, these are tubes which have been in the hospital, they've got nosocomial infections, they are quite resistant, some of the pneumonias they develop. So if you put a tracheostomy, it's new, it comes out of the package for the patient, and you put it on the patient, they are highly unlikely to end up with a VAP, the same ventilator-associated pneumonia. Then it also prevents airway stenosis. Airway stenosis, meaning your patients who can end up with a tube which is sitting inside the airway and it's got a cuff, because when you intubate them, except for the children, some of them don't, it's not cuffed, but these other tubes, usually from size 4 all the way to size 8, they're all cuffed. Because you want to make sure that you are ventilating, and 1, 2, you are increasing the pressure. So that movement, the high pressure of the cuff causes pressure on the necrosis, and then the airway also starts swelling, stenosis, tracheal and laryngeal malacia. So when you put the patient on a tracheostomy or do a tracheostomy, you actually prevent this complication of irritation of the airway, of the vocal cords. So the vocal cords can stenose, subglottis can stenose, and therefore the tracheostomy is indicated in all these patients so that you don't have these problems. 5, it improves the patient's comfort. When we say comfort, not that the surgery is not painful, it is, but overall the patient will be able to talk once tracheostomy, especially if you take them off the ventilator or via the oral cavity and oropharynx, patient can talk. Even if he's awake, he can talk, swallowing, Patient has got a tube, has got a nasogastric feeding tube. Patient who gets a tracheostomy might be able to swallow better and actually can even start sipping if once their Glasgow Coma scale is higher as compared to the others. So they can even sip as long as they're able to swallow, and the length of the tube is less, and therefore the tracheostomy. Also sedation. The amount of sedation that you have to put in a tracheostomy patient is less because the tracheostomy is fixed to the neck. Patient is highly unlikely to pull it out, but also it's a shorter tube, it's much less painful, and the patient, you'll be able to wake up your patient more. And therefore, of course, the patient has less disorientation. So the criteria.
Ida Kawisha, you're welcome. Kindly unmute your mic. Thank you.
Criteria for tracheostomy in ICU. So, one, as I already mentioned, patients who got prolonged intubated. They've intubated for 10 days on the ventilator, the mechanical ventilator, or they had previous history of intubation, even if they've been intubated less. If they went to the ward, you intubated them for 5 days, they came back, you intubated them again, you add the other 6, 5, you have got still a total of 10 days. Children, you could put them, since they have got no cough, you can do 14 days. So, as already mentioned, prolonged intubation ends up with problems. So your patients, those who are intubated, should be consulted to have a tracheostomy, whether general surgery, ENT surgeon, even maxillofacial can do the tracheostomy. So I already mentioned the excessive pulmonary secretions, the pulmonary toilet, where the patient has got a lot of secretions. Every time you hear it's a wet chest, you hear in the tubes, there's a lot of secretions. So one of the things that you want, you're forever suctioning a lot, you see the color of the secretions is yellow thick. You can end up putting a tracheostomy to try and reduce the irritation if query infection, so as to help the patient. The patient can even start coughing up the secretions themselves on a tracheostomy. Failed extubations with multiple intubations, criteria is not, there's no standard criteria. But I mean, if your patient, you've intubated your patients at least twice while in ICU, and they extubated, and then meaning you've caused trauma in that airway. You've caused trauma to the larynx, meaning there is swelling, there's edema, and high likely there will be next granulation and scarring. So such a patient, instead of you extubating, fails, you intubate, it's more than 2 times, 3 times, then that patient should just have a tracheostomy, so as to prevent the issues with the multiple intubations and injuries. So then the other one is failed weaning of the mechanical ventilator. You extubate, you try and reduce the settings on the ventilator. Your patient doesn't get, he's struggling to breathe. The pressures are high. Of course, there are those people who need high pressures and they might still need high positive pressure. But even there, you can use a cuffed tracheostomy. But once you're failing to wean, the tracheostomy will reduce the dead space. It will reduce the effort needed to breathe by the patient. So it helps. And eventually that you can just put a tracheostomy and the patient might get. The 5th one there is irreversible brain damage. Patient has got systemic sepsis, in this case, viremia. Patient had encephalitis, encephalitis, and you've seen that the patient thromboembolic phenomena, they can end up with the CVA from the COVID itself, and you've seen that GCS is not improving. So meaning this patient is not able to protect their airway. They can easily aspirate. So even if you extubate them, you are going to end up a patient with aspiration pneumonia. So that patient needs to have a tracheostomy so that the air is protected. Even if you try and feed them, you're not really worried. And the patient can go to tracheostomy for how long? It might be permanent. And Doctor, you want to do the post-notice?
Okay. So we're going to do our pause questions. Let's have a look at them. We can answer them now based on what we've learned or heard. Then at the end of the presentation, again, we'll go through and see.
Yes, I see. No. Okay, people can try the questions and see what you can get. We'll give you a minute.
So it says patients in ICU who have prolonged intubation and are extubated can develop dysphagia and dysphonia. So dysphagia is just difficulty swallowing, dysphonia, loss of voice.
True, of course.
So we can attempt to have about 5%.
1 out of 8.
Where are other 17 participants? Ed Mulenga, are we answering? Okay, we'll move on to our next question.
Show the results. Info. Give you the results.
So we only have about...
Share results. Okay.
That's true.
Okay.
Let's look at the second question. Can we all participate, please? Size of the endotracheal tube can be a risk factor in developing tracheal stenosis. So the tube you use to intubate your patient, does it have any effect on whether your patient will develop tracheal stenosis or not? Is it true or false?
We'll try, attempt. Try and attempt the question. See the size of the endotracheal tube. That one we put in ICU. Do you think?
Okay.
Okay, saying you can't see the poll question on your screen. Okay.
It's only flashing for 3 seconds. Apologies for that.
And iPhone, we're not sure who iPhone is, but
kindly name, Mr. iPhone or Miss iPhone, rename. When we log in, let's use our names, please.
Yeah, put your name so we can address you properly, so to know what problem. Can everybody see the poll questions? Because the ones who are posted there, they say they can't see the poll questions.
Are we able to see them now?
Okay. Let's see. Oh,
Xavier, you still can't see the poll question?
you still can't see the poll questions?
And because you haven't launched it, it's on sharing.
So share, stop sharing.
Yes, you have to either relaunch or something.
We
Okay.
need to relaunch.
So you stop sharing, then maybe you launch or something. Launch, yeah.
Okay, we've tried to relaunch. Can you see it?
The size that you use for you, does it matter?
Okay, so we've relaunched it. Okay.
Mm.
Yeah. Okay. We're waiting for some people. Still waiting for some more people. 30 seconds to answer. With 15 seconds. Okay, 10. Anybody else answer? Okay.
Okay. So all of us actually answered it's true. Yes, size does matter. You use a bigger tube in a child, you cause definitely injury, and this can lead to stenosis.
Okay.
Our third poll question.
What is it? Go back. Oh, there means the other one haven't launched. We haven't ended it. Yeah, stop sharing. Stop sharing. Oh. Okay. Prolonged intubation is 10 days or more.
Is it true or false? Are we able to see the question?
Yeah, we've got 20 more seconds. The chat, check us on the chat.
Okay, Miriam, you're unable to see the poll question? So,
Okay.
can you see it now? No.
Okay.
Is that a yes you can see or yes you cannot see?
Okay, so it's in the pool. Okay. So as you can see there, prolonged intubation is 10 days or more in ICU if a patient has got a tube. Therefore, they should now be considered they are 14 days for pediatrics. Okay. Then we're going to the last in the pool. Sorry. Wrong poll. Okay. There in long COVID, patients who come with stridor and host voice should only be X-rayed in the chest. When they go for X-ray, you order the X-ray, you ask them, please do chest X-ray. So you want them to do chest X-ray? Only? Okay. Okay, we've got 6 more seconds before 3. Okay. We've ended the poll.
Okay.
Let's share the results there. The patients actually who actually come with that should also be X-rayed elsewhere because the problem is in the neck as well. So it's chest and neck X-ray. So thank you. Let's continue with our presentation. Okay, so as already mentioned there, these are the complications, both from the tube, because we know they're both tubes, tracheostomies and ET tubes, endotracheal tubes, which is prolonged. They can both cause complications if they stay too long. Of course, you're going to swap an endotracheal tube for tracheostomy because some of these are less in patients with tracheostomies. Tracheal stenosis, which is more going, these patients can end up with tracheoesophageal fistula, which is the fistula or the connection between the trachea with the esophagus. Tracheocutaneous, where the trachea, because of pressure, there's a hole which is made to the skin. Tracheoinnominate fistula is where from the trachea, because of pressure, it goes to the blood vessels. This one is very fatal. I think people have ever seen this, and it's very rare. The survival is less than 1%. Granulation tissue, whereas in where you've put the tube, it's irritating, it starts causing granulation, especially like the tracheostomy. Here around the stoma, you find granulation tissue. Even the endotracheal tube, except the granulation tissue will be elsewhere, like the vocal cords. Poor voice quality, that's the dysphagia. So you can have granulation where there's scarring around the larynx, the vocal cords, and there can also be a web formation. There can be injury when you're intubating. Like we said, intubating, we sometimes intubate blindly because you can't see the air with secretions plus. So you can end up causing even palsy of the vocal cords, injuring the vocal cords, stenosis, a web just around the vocal cords. So patient has got poor voice quality, even with a stride. Dysphagia has been mentioned. The tube, if it's big, it's pressing on the esophagus posteriorly, whether it's the trachea or the endotracheal tube. Patient can't feed, but even we rarely feed the patient, of course, with an endotracheal tube. So the ones who complain of dysphagia are the ones with tracheostomies. Tracheostomies in ICUs. Locally, we have not seen any studies. None of my colleagues under anesthesia or those who are intensivists would have mentioned what is the rate of tracheostomies there. Done per, let's just say if you want per year or even per 100 patients, depending on percentage of your patients. But our colleagues who have done some studies internationally showed that 8 to 13% or 15% who have been in ICUs, they often might end up having a tracheostomy. But during Corona pandemic, because of one, the issue of guidelines, some patients, it varied from hospital, region to region, country to country. So some the rate of 16%, which is already higher than the normal rate. to all the way to 60%. Some people were putting the tracheostomy after 7 days. Some people were using the time of 14 days, and some other criteria to put tracheostomies on some patients. So this varied, but as you can see, there's a general increase of tracheostomy rates in ICUs during the COVID pandemic. The mean number in one study showed the mean number of endotracheal intubations. Extubation was 17 days, which is 2 weeks, almost going to 3 weeks. The main post-intubation symptoms were dysphonia, the voice, dysphagia, and dyspnea. This is in this is more than 3/4 of your patients. Then dysphagia was the least. So these were patients who were intubated and extubated and assessed. So these were not, these, we can't really say these were long-term, but they were mid-term complications, but just show you how frequent some of these things are in our patients when they've stayed in the ICU, because sometimes we don't do post follow-up patients once they've been intubated or put to the tracheostomy. So rate of tracheostenosis. Rate of tracheostenosis in a study, I think study was done in 2023 or 2020, after 2024 or 2023 or 2022. So it was published then. So these patients, there was a rate of 8.5%, 24%, or 24 patients. So this group had more than 100 studied, and they show that those patients who were intubated, and using, as you can see, the median time of following up these patients was more than 3 months. This is 4 months, almost going to 4 months, 3 months. They found that of these patients who had undergone intubation, these are COVID patients in particular. They found that 24 of those patients had developed stenosis. And all these patients had been less than intubated than 200 days, which is a lot. But of course, this was a follow-up period of time, following up the patients after they come ICU. See at least of those patients, quite a number of them developed tracheal stenosis, which is one of the more common, it's more common than we think. And that's the issue that people forget. Patients come with these issues and then we forget to look in the upper airway, that we caused trauma. This patient was in ICU and we should have followed them up. So what factors can also play in the patients who have, which you end up with tracheal stenosis? Prolonged intubation, we already mentioned. 14 days, but of course, like I said, in adults, it's usually 10 days. 14 days plus is usually for pediatrics. So if you are keeping the patient, you know your patient has been on the endotracheal tube more than 2 weeks, more than 1.5 weeks, you are keeping the patient too long on the endotracheal tube. You should now consider weaning them off and lessening the number of complications. Repeated intubations. Like we said, some intubations are blind, done in emergency setting. You do it more than twice, you are now going to cause injury to the larynx. It's going to be edematous, scarring. High cuff pressures. So unfortunately for our ICUs, we don't measure our cuff pressures. We just get the syringe and go blow the balloon and we never check the cuff pressures. So if your patient have got more than 30 centimeters of water, ideal cuff pressures are actually supposed to be somewhere like 22 to 26 centimeters of cuff. So no cuff pressure, deflating the cuff is going to lessen that pressure in the airway. But you have people with, we have not measured the cuff pressures, goes all the way to 30, some even go up to 50. That's the one which will cause short term within the week. You're going to have a very swollen or edematous larynx. Size of endotracheal tube, wrong sizes. What I mean is that you must look at your patient. Some patients, unfortunately, some patients can be obese, some patients can be small, so you must look for a smaller tube. Do not try and put a large tube. You are putting on a teenager, you go and put them a size 7. Try and look for the size tube. You look, rough estimates, they use fingers to show how big the trachea of the patient is. So you use thick tubes, more injuries. You use slimmer tube. Of course, those which are not cuffed will cause less injury, like I said, especially in the pediatrics. Use of corticosteroids have found that they reduce inflammation and swelling, therefore reduces the risk. Presentation of these patients, how do these patients come? So this is what happens even when you see these patients. One, of course, that history of ICU is number one. So this patient will come after undergoing the surgery or procedure. What I mean is that they've been intubated 6 weeks ago. It says, oh, I was even here some weeks ago. And these are patients I got called for. I think the time I was doing my training, I saw, when I went back, some of the patients, and every time when I go to consultation is when I ask, doctor or sister, did you ask that person? That person, have they been in ICU? Were they admitted? They don't know admitted, but did you ask where? ICU stay. They come almost 2 months, so they'll be fine. And you say you've gone home, and then your patient comes back with dysphagia, with breathlessness, with a cough, a persistent cough, hoarse voice, and that's stridor. The stridor could be inspiratory, and sometimes it's very subtle. It's just a low volume noise, but it's there. And the patient says, that'll be nice. You just know that you must check that patient's larynx and upper trachea. They might be having stenosis. So the investigations of the complication with tracheal, like we mentioned, X-rays. Most of us, we know that we work from, at least we have access to X-rays. Soft tissue X-ray, lateral and AP, both of the chest and the neck, both. I didn't say just of the neck, but I said both. Because you can have a tracheal stenosis, which can be in the trachea, which is found in the thorax. So you must do X-ray, soft tissue. You're not trying to see the C-spine. Tell your radiographer you want X-rays of the of the tissue. It's the same one that you take when you're doing epiglottitis or an abscess. You want the tissue. So when you see that one, then it can tell you if your chest looks fine, and you ask, and that's a good thing with the digital X-rays now. You can send them to someone who's also a radiologist. You can send them to a surgeon. You can send them to a senior. You can send to a lot of people in your patient. Why is this patient coming with dyspnea, exceptional dyspnea, dysphonia? Oh, they stayed in ICU. Let's see their chest. We want to know whether you're going to refer this patient to internal medicine or pulmonology, or you end up with the ENT or cardiothoracic. Then this patient, if you see, you can't really see this. Of course, endoscopic visualization, laryngoscopy. So laryngoscopy stroke bronchoscopy. Why? Because like I said, if it's stridor, you know it's the upper airway. The patient can even come with some stridor, even if it's just mid-trachea, it's in the chest. So you might need some visualization. So you need a specialist in this case, or those who are able to do laryngoscopies, bronchoscopy, flexible ones. These are done in OPD. We do them at Levy, we do them here at UTH, you send the patient. If you're far, like we said, if the CT scan is nearer, then do the CT scan. But otherwise, you do the laryngoscopy, flexible, and there are a few places which have, minor Soko also has, so they'll do that. Other private hospitals have, but the public, only the big hospitals. I think Dr. Lukama in Dola is also doing the flexible scope actually. So even there in Dola, he's able to do that and visualize for you. You can ask cardiothoracic who are at heart disease hospital. I'm not sure if I'm sure they are doing the flexible scopes and bronchoscopes. They can check for you. So the next thing, of course, if you are unable to access this facility, if you are near the CT scan, if it's nearer than your endoscopic viewing, you can end with contrast. You can focus on the airway. You can even tell the radiologist, write it on the form. They can do a 3D reconstruction of the airway. So this is a 3D reconstruction, and they reconstruct almost the whole airway, almost up to the bronchi, and it's 3D. It will show you the dynamics of the airway, and they will tell you if there's any stenosis, it will show up. So these are images which were done in some COVID patients post-intubation. And as you can see, from A up to H, all those H, all of them have got problems with the airway. A, as you can see, they're putting there, if it's a suction, they're suctioning there. You can see the vocal cords is irregular. There posteriorly, the right one looks not so bad. The left one is got a So the whole point is that supposed to be the vocal cords are supposed to be on airway in between, and then you can stridor and the cough. It was not even stridor, it was dyspnea. It was the patient was just struggling. So if you just went and did a chest X-ray and checked the chest, you would think the patient is fine. But you forgot to image the patient's neck. And you find this patient, she presented 2 months later, saying, I can't breathe, I'm tired, and there's constant cough. This cough had been there from extubation, but had worsened in the past 2 weeks. So this patient ended up having, it was actually a tracheal stenosis in the upper airway. So I end here. I'm not going to go into the management because the management is very specific, and it is ranges from surgery. But most patients who are going to come that needs to be referred, they need to be put on medication, steroids. If you have inhaler or nebulize them, you need to nebulize them. And obviously you admit them. The patient has to be put, you even know that if you are going to try and intubate, you must use an experienced anesthetist, so senior. So that is where we end. And I'm going to maybe hand over to the facilitator.
Okay, so thank you so much, Dr. Mwale. There are any questions from our participants? Anywhere where you're not clear, clarifications? Please feel free. You can raise your arm or type it in our chat box as we do a summary. So basically, we've all heard, like last time we discussed what defines long COVID. So as in ENT patients, tracheostomies are a common thing that we get called for, like Dr. Mwale said. And then tracheal stenosis is common than we come to realize. It being attributed mostly to the COVID pandemic that we had. As we saw, the statistics have raised. We used to have 8 to 13% of patients being intubated in ICU, but now after COVID, it's about 16 to 60%. So that tells us that we have to be vigilant and be careful so as not to cause tracheal stenosis in the aftermath after our patients are discharged. It's imperative to know when to call and who to call when you're having a patient presenting to you with dysphonia, they're having poor quality voice, they're having difficulties breathing, having stridor. Is clearly stated, you can call an ENT surgeon, you can seek help of a pulmonologist after you've done your assessment. So you look at your patient, the soft tissue X-ray of the neck as well. As we've seen, tracheal stenosis happens in the neck. So you forget that, you do the chest, you may find out nothing and lose a patient. And then most of the indications we've seen, if a patient stays in ICU on intubation, is a bigger one, you can actually cause, or you have increased cuff pressure, you can cause pressure necrosis at the point where it's ballooned. If it's a big tube, you can actually cause tissue injury to the trachea as a subglottis. It's just right above the trachea and below the glottis region. So we use the right tube. A patient stays in there 10 days more, and you have to make sure you call after 10 days, you call for a tracheostomy. If you put a tracheostomy and it's prolonged, we've seen the statistics and studies shown that stenosis was reported. Usually these patients, Dr. Mwale has highlighted, they'll present to us 6 weeks post-discharge or post-extubation. It's very imperative that as we manage these patients when they first come, we call the right people and we use the right tubes as well. Monitor our cuffs, which is, I don't know how easy it is locally, but for tracheostomies, Dr. Mwale has always emphasized 24 hours post, you should reduce the cuff pressure to prevent necrosis. Also, for those who maybe joined late, some of the indications for tracheostomy. First one, prolonged intubation. If you have a patient with increased secretions that you're tired of suctioning, there are times when we are constrained, you have a lot of patients, you may want to do what we call pulmonary toilet. You go for a tracheostomy. Other than that, you can also have patients who have a trauma, neck trauma. All those people come in, you need to put your tracheostomies as well. Are there any other questions? Or any clarifications? Remember, of all these, the most common complication you see is tracheostenosis. Okay, so if there are no questions, that means we are all clear. And then most of us actually answered the 4 questions correctly. For those who came in late, we'll just relaunch and see. So our first 4 question was, patients in ICU who have prolonged intubation and are extubated can develop dysphagia and dysphonia. Is it true or false? So since we already answered, we'll just go through them quickly. So the answer for this was true. So Dr. Mwale emphasized those who have dysphagia mostly are those who had tracheostomies. And then it's very important that you be careful because you can cause fistulas. He has highlighted different types. Among the common ones, we have a tracheoesophageal fistula. Our second poll it was asking us about the size. So size of endotracheal tube can be a risk factor in developing tracheostenosis. Was it true or false? So the answer for this as well was true. And it's important that you don't prevent trauma, iatrogenic trauma. Also pay attention to the cuff, the pressure that you put in there, how balloon you keep it. If you do a tracheostomy 24 hours, kindly reduce the cuff pressure. Our third poll question it was asking about the duration of intubation. So prolonged intubation is 10 days or more. True or false? Of which we've seen that is true in children for 14 days or more. And our last poll question. Patient who comes with stridor plus hoarse voice should only be x-rayed in the chest. Dr. Mwale has clearly stated that we should always ask for a soft tissue x-ray, including our cervical region. We don't want to see the vertebrae, you want to see the soft tissue. And then if you don't have an ENT or you don't have a pulmonologist, cardiothoracic surgeon nearby, but you have CT, kindly order a CT scan, it will be very helpful. If there are no more questions, I would like to thank everyone for upholding our rules. I didn't hear any phone ringings. Thank you so much. Thank you for your participation. We will be meeting again on the 24th of April, and the topic will be shared pretty soon. Thank you so much, and have a great day.
You too.